Good afternoon, everybody. I'd like to welcome you all to our second to last session of the APDR National Virtual Noon Conference series. We're in week 17, and this is our final week, and we're very excited for this week's speakers. My name is Dr. Harp Beatty. I'm the chair of the Education Committee for the APDR and Neuroradiology Fellowship Director at Boston Medical Center. Again, welcome. As we do every session, a few housekeeping items. As you know, the session is being recorded and will be hosted on the APDR YouTube channel to view on demand for free. The questions and comments will also be recorded in addition to the presentations. Your microphone as attendees are muted to ensure optimal quality for the participants. And again, if you do have questions for our presenters, we ask that you use the Q&A tool through the Zoom platform, and we'll get to those as best we can. It's a real honor for me today to introduce our speakers. Dr. Marx, Professor of Radiology, Vice Chair of Radiology Education at USC, also the current sitting president of the APDR, will be speaking on trauma intervention, a case review, and Dr. McKinney, also Professor of Radiology and Chair of Department at Mayo Clinic, Jacksonville, past president of the APDR. So it is really quite an honor to have both of our speakers today. Their dedication to the radiology education landscape and leadership goes without being said, and we're really privileged to have them take time out of their, I'm sure, unbelievably busy schedules to give talks today. So without further ado, I would like to invite Dr. Marx to, I'll stop sharing my screen and invite her to begin her presentation.
Well, listen, I want to thank you, Harpreet, for leading this educational effort on behalf of radiology trainees. The APDR is very proud to sponsor it, and hopefully it is and will continue to be valuable to trainees moving forward. So thank you for all your time. I also want to take the opportunity to thank APDR staff for the behind the scenes work they've been doing to make this all possible. Anyway, I'm going to talk today about trauma intervention and use a case-based review to give you guys ideas about how we manage trauma in IR. I have no financial disclosures, but I will be showing some things that are off-label use of medical devices and drugs. By way of background, for the last 20 years, have been full-time IR faculty at University of Southern California. Our main educational venue is the Los Angeles County Medical Center, which is a level 1 trauma center. The hospital has a 150-bed ER and actually trains some U.S. military medical people in management of trauma. We see 3 basic types of trauma: blunt, penetrating, and iatrogenic. Most iatrogenic trauma is penetrating trauma. And frankly, we don't see as much street penetrating trauma as we used to. The majority of people who suffer blunt trauma in our current experience are pedestrians. And I'm not sure if the people driving the cars are texting or the people walking are texting, but that has been a real uptick in the last few years. When we get called to help manage trauma patients, generally to stop bleeding, we have a lot of considerations that come into play in our medical decision-making. First is the patient's hemodynamic stability, including their response to fluid resuscitation and blood products. Then there's the imaging findings, typically CT, the hematocrit trend, the age. We are more prone to intervene for mild things in very old people than the very young, because they really have very little reserves, what their underlying comorbidities are, and of course the operator preferences and skill sets. We have, for embolization, we have a large number of devices available to us. In the middle of your screen, you see gel foam. Gel foam's been used to be injected into bleeding arterial beds for over 40 years. And this is clearly an off-label application of this. We have coils. Gel foam is a temporary agent and is not really used when you need a precise arterial occlusion. Coils, there's a lot of different types of coils here. I'm just showing you a few. These are permanent agents that are very reliable. They do require that the patient have intact platelet function and clotting cascade to work, and they can be very precise. For large vessel occlusions, we have some larger devices that can be used in major arteries to give segmental occlusion of the vessel. And then we have 2 liquid embolic agents, and we do use these off-label for trauma patients. This is Onyx, and this is N-butyl cyanoacrylate glue. And the differences in our decision-making in which we use has to do with the patient status, whether we want to use a temporary or a permanent agent, whether we need a proximal versus a distal embolization, whether we need to be precise or very imprecise in where the embolic agent goes, and how long it takes. There are some patients who don't tolerate much time in getting the procedure done. And there are some interventional radiologists who don't tolerate much time in getting the procedure done. So I'm going to just show some cases now, and I hope my video works. Let's think good thoughts. This is a CT scan of a trauma patient who came in after being hit by a car while walking across the street. And you can see here there's a very large liver laceration. There's multiple punctate hemorrhages within the liver and high density blood in the peritoneal cavity. He was referred to us. We did an initial celiac arteriogram. Here I'm showing you early and late films, and it's not dramatic in the amount of extravasation you see, but on the delayed films, you see multiple little punctate areas of contrast that are in the areas of laceration. This patient was not doing well clinically, and we decided that a temporary broad occlusion with a temporary agent and a very non-specific distribution was what was called for here. And here is an image of the right hepatic arterial tree after we've showered it with gel foam particles suspended in contrast. And you see that the hepatic arterial tree is pruned. Patients in this situation do develop spike in liver enzymes, and we would be cautious about doing this in people who come to us cirrhotic or have a cirrhotic looking liver, but this patient tolerated this quite well and had no further intervention necessary. Here's another patient who was another person who got hurt by texting, either by the driver or the walker. He presented to the emergency room very unstable. He was put on a massive transfusion protocol, and he was RB'd to the OR without any imaging studies. RB is a colloquial term used at LA County for red blanket. So in the olden days, when you'd have a lot of casualties, anybody who needed to go straight to the OR from the ER would have a red blanket thrown over them as a sign that they just needed to head up to the OR. We don't have red blankets anymore, but we still use the term. So here's a picture of the angiogram done in our hybrid IR-OR suite. The patient has multiple surgical sponges in place attempting to tamponade the bleeding liver. But he was still bleeding. You could see blood coming out of the open incision, and we were called. So here's our initial arteriogram. Let's hope again. Oh, it's working. And what you see here is a huge amount of contrast extravasating from the liver down into the patient's left lower quadrant and coming off a fairly specific point on the undersurface of the right lobe. So after this, the operator used a microcatheter, and here you see a little pseudoaneurysm. It doesn't look as dramatic now. That frequently happens once you catheterize the bleeding vessel because the catheter itself impedes arterial inflow. And the operator coiled this vessel and then one immediately adjacent to it. And you can see misregistration artifact here on the post-embolization run. And they used coils. Now, this is where operator preference comes into play. I probably would have used glue here or Onyx because I think it's faster. The downside of using glue or Onyx is that if you don't get a complete occlusion, you have to get another, you have to take the microcatheter out, it's useless, and get another microcatheter and recatheterize the vessel to get back. So there's always trade-offs. I'm sure Mark and I have different opinions on what to do. And here's a final film with these coils in those branches of the right hepatic artery, and this patient also did okay. But he had more adventures that required ongoing IR care. Several weeks later, it was finally figured out that this collection under his liver was a myeloma. Here's an MRCP showing the communication of this fluid collection with the biliary tree. So for diversion, he was given a drain in the myeloma, and then we did a PTC and biliary drain. And here you can see on a cholangiogram that there's a duct that is heading down and leaking contrast right adjacent to those arteries that were bleeding. So he has a bile duct leak. And sometimes these heal just with diversion, and sometimes they don't. This one didn't. So we embolized the bile duct. And here's a little reverse curve catheter with a microcatheter down into the bile duct, and we filled it with glue. This is an off-label use of glue. And here it is. The glue is permanent. It's faster. It can be precise depending on what it feels like doing. It also does not depend on coagulation to occlude a tube. Another thing that's useful with glue that I didn't mention before is that if you can't get your catheter tip all the way to the point of the tube that needs to be occluded, it will flow with blood flow. So in the arterial tree, it's very useful when you can't quite get your catheter to where you need to go. So this person eventually, after about a 3-month hospital stay, left the hospital without any tubes in and did okay. This is an elderly woman. She's 85 years old. She had a ground level fall. She presents to the ER. She actually has a pelvic fracture anteriorly. She was hemodynamically stable. You can see she's had a hip replacement in the past. And on her CT scan, she has a very large pelvic hematoma anteriorly and on the left side. And she does have a small amount of extravasated contrast in the region of the left obturator artery. Although she was hemodynamically stable and required no blood transfusions, we did elect to do an embolization procedure, or at least study her for embolization due to her advanced age. And you can see here she's got some atherosclerosis, tortuous blood vessels. All the bleeding we saw on the CT was on the left side, and you can see on this arteriogram that she has some little punctate areas of hemorrhage in the region of her anterior pelvis near the obturator foramen. And what you may or may not appreciate here is that her obturator artery is arising from her inferior epigastric artery. And this is a very common anatomic variant that we need to know about when we're doing pelvic embolization procedures. So here was on your left is an internal iliac arteriogram. We didn't see any bleeding from this. In a person who is hemodynamically unstable or in a younger person, we might prophylactically embolize this with gel foam in a person with pelvic fractures, because oozing can continue from all the sites of muscle tears and fracture lines. But in an older person who may have difficulty healing, we try to be more precise. So we did not do an internal iliac embolization procedure in this patient. We went and found her obturator artery arising from the inferior epigastric artery off the junction of her common femoral and external iliac arteries. Selected that. We're actually able to select it with a 5 French catheter. You can see here's the bleeding adjacent to the obturator foramen. And then we actually just seated the 5 French catheter further and put a little bit of gel foam out here. We're very cautious, in part because of the concerns about healing in people with advanced age and atherosclerosis. She did fine. This is another gentleman, another person who had a pelvic fracture, and he's 37 years old. He fell from an apartment balcony. The reason he fell from the balcony, this wasn't suicide. This is a man who locked himself out of his apartment. So he went to the apartment above his to have a neighbor let him in. And then he was trying to access his balcony by climbing down bed sheets tied to his neighbor's balcony, and he slipped and fell to the ground. So he has a huge pelvic fracture. You can see the posterior sacral fracture and then the diastasis of the pubic symphysis. On his CT scan, he's got a big left-sided pelvic hematoma with a little bit of maybe a pseudoaneurysm at the sciatic foramen, and then he's got some punctate areas of extravasation along the right obturator foramen. He also had an extra peritoneal bladder rupture, which complicates the interpretation of the CT scan. But he came straight to us. You can see here on his pelvic arteriogram that he's got extravasated contrast on the left side of his pelvis and on the right side of his pelvis. He's very clamped down. On the left internal iliac study, you can see the extravasated contrast. Now, this is a situation where one person might choose to try to get selective and just embolize this vessel that's bleeding. In the setting of somebody on a massive transfusion protocol, we decided that we were just going to gel foam the entire internal iliac distribution on that side in the interest of time. Once we did that, we looked at the right internal iliac and did the same thing, and then noticed that, like the elderly lady, his obturator artery comes off his external iliac artery. So we did an external iliac arteriogram here, and then subsequently catheterized this little obturator artery, and actually here's a microcatheter in it, and we actually managed it with glue. And the reason I used glue was I couldn't get the catheter way out there. I was quite worried about refluxing into his femoral arterial tree because he was so clamped down, and I didn't think we'd get much gel foam out there and it might not be durable. So the decision I made was we did gel foam through the big distribution on the left and glue on the right. And here's a picture of the glue. And this obviously is an off-label use of the glue, but you can see here that glue got way out to the little branch that was bleeding, and this is actually contrast that had extravasated prior to the embolization. Now let's talk about the spleen. This is a young woman who was in a motor vehicle collision, and she was transferred to us from an outside hospital because they didn't have any interventional radiology. This is the CT scan that came with her. You can see she's got a lot of blood in her peritoneal cavity, and perhaps pseudoaneurysm or some extravasation in the splenic hilum. By the time she got to our institution, she was quite stable. Her abdomen was benign, and so she came to IR for us to see what to do. And this is another area where I'm sure Mark and I could argue for quite a while on what the right thing to do is. But on her splenic arteriogram, she had no extravasation of contrast. We saw no pseudoaneurysm. This in the hilum, this here is actually a curlicue, and then we did obliques to sort that out. She had no pseudoaneurysm or arteriovenous fistula, and she was hemodynamically stable and not requiring any more blood products since she got to our institution. So we decided that that we didn't see a reason to do any selective embolization in her, and we put a proximal plug in her proximal splenic artery, which is a permanent device. And the goal of this device is to decrease the volume and pressure of arterial flow to the spleen, but has really no risk of splenic infarction as long as you position it in a place where collaterals can get around it. So on the early phase after placement of the plug, we see filling of the left gastric artery and the gastroepiploic artery, and then if those two things through short gastrics and through the gastroepiploic arcade and the pancreatic vessels reconstitute her splenic artery. And here's what the little plug looks like. This is actually a what it's indicated to do. And she did fine. Here's another splenic injury. This was another driver. We don't, like I said, we don't see many drivers get hurt anymore. Mostly it's the pedestrians. But this was a driver in another high-speed motor vehicle collision. He had this CT scan, which didn't look very impressive. The upper pole of his spleen you can't see very well, but there was very little fluid, blood in the peritoneal cavity. But right after this CTA, he decompensated and started requiring blood products. So he came to IR, and what we see here on 3 sequential images is there's areas in the upper pole of his spleen with extravasated contrast. As you move on, it gets more dramatic and it stays there. And this looked to us like why he was bleeding. So in this case, since it was all relegated to the upper pole of the spleen, the operator in this case found his way out to the upper pole and put coils in the vessel that was bleeding, and it seemed like all those extravasations were coming from one splenic artery branch, and did that before he placed a plug in this proximal splenic artery. And the thinking here was that this was more likely to continue to bleed because of the nature and the injury and the way the patient presented, and we didn't want to put a plug in the proximal splenic artery and then have no way to get back in. This is a very interesting case I just did recently. This is a young girl who, I forget how she was injured, but she had a fractured dislocation of her humerus, where the greater tuberosity of her humerus was avulsed, and went to surgery to have that repaired. And you can see the orthopedic hardware in place. And she developed really severe pain and swelling of her left shoulder about 5 days later and came back in. She had a CTA. The axillary artery is associated on this CTA with an ginormous pseudoaneurysm of the axillary artery. Her left wrist pulses were intact and fine. And so the question becomes, how do you embolize this? What do you do? How do you make this go away? Well, the answer isn't embolization. The answer is to close the hole, because this was a big hole, presumably related to these screws. So what we did after we did our subclavian arteriogram was get a microwire past the disruption, which took a little bit of doing because it just kept wanting to go out the hole, and then load a Viabon covered stent over that microwire. And this was, I think, a 6 millimeter, 5 centimeter long stent. We had a sheath, a long guide cath in the subclavian artery so we could position it precisely, and then we deployed it. This is actually the stent deployed. Here you can see the little markers at the ends of it, and now we're not filling that pseudoaneurysm anymore. What those of you who are looking closely will see, however, is that we got a little clot that probably bounced off the edge of the hole where the turbulence was. A little clot here in the brachial artery that's probably partly going down the deep brachial artery, which is probably why it got stuck right there. And then we had to decide what to do about it. The patient had, her fingers were fine. She had intact 2+ pulses, and she's only 15 years old. And when you start, the more you mess around in the peripheral arteries of a young person, because they're very prone to spasm, you can get into a cascade of making things worse. So we elected to do nothing at this point. And she did fine. She had a follow-up CTA a few days later, and that thrombus had disappeared, and she had no sequelae from it whatsoever. So this is one of those things, I don't think there is a right or wrong decision. And fortunately, the decision we made worked, but it's an illustration of the nuances that occur during medical decision-making in interventional radiology. Let's see. Oh, and this is this is another iatrogenic one. This is a gentleman who had a large left-sided renal cell cancer, and he had a robotic partial nephrectomy and then developed some mild flank pain. And what we see on his new CT is that he has an even bigger pseudoaneurysm. So iatrogenic injuries cause big pseudoaneurysm in the robotic nephrectomy, partial nephrectomy bed. So we were called in, and in this case, you can see it filling off a single branch of the renal artery. And here, he's already had half this kidney removed. You want to preserve as many nephrons as possible. So a very precise embolization is what's called for here. And we packed coils into this little branch, preserving the rest of his residual kidney. You'll notice on this picture that there's a coil out in the pseudoaneurysm, and I'll show you how that happened. We were just a little bit too far out, and boom, Yep. Well, fortunately, there's no sequelae from a non-target embolization into a big blind pseudoaneurysm. Finally, this is only in LA. This is a bicyclist. He was run into by a car, and then the car's driver got out and stabbed him. So presumably the car was chasing him. Anyway, so you see he's got a varifocal liver lac, and he's got extravasation from his kidney into the retroperitoneum. He was taken to the OR and had lacerations covered, but he was still bleeding. So we were called back up into our hybrid suite, and you can see here that we're doing a right hepatic arteriogram. This almost looks like a tumor, right? I mean, this is very bizarre looking, but the hepatic arterial tree can look very odd when it's being pushed around by surgical sponges. We didn't see any extravasation here, but he did have arterial portal shunting. So you're seeing some portal branches light up. And presumably that is related to the injury or perhaps to the packing, changing the pressure gradient, who knows. So we went ahead and gel foamed that circulation mainly to treat the surgeons. And then we looked at the kidney, and at this point, we don't see any of that extravasated contrast. They did not open the retroperitoneum. And as you know, the peritoneal cavity can expand it infinitely, but the retroperitoneum can't. And he had stopped bleeding from his kidney. So we decided not to do anything. And that's one of the decisions that we have to make in interventional radiology, is when not to treat. He did fine too. So in conclusion, I hope this illustrates to you how key interventional radiology is in level 1 and level 2 trauma centers. Arterial embolization is a critical component of trauma care, and multiple factors impact IR patient management decisions in the setting of trauma. These include the patient status, the location of the injury, imaging findings, the embolic agent characteristics, and operator experience. I hope you enjoyed this. And again, I want to thank Harpreet Bedi and APDR staff for making this series of noon conferences possible. Thank you.
Thank you so much, Dr. Marx. Great presentation. And again, appreciate you taking time out of your schedule for this initiative. With that, I'd like to introduce Dr. McKinney, and if you could share your screen and begin your presentation.
Thank you, Harp. It's a pleasure to be here and talk to everyone. I am glad to support APDR in this lecture series, and I enjoyed Dr. Marx's lecture. And Vicki, I just want to let you know I'm a big fan of proximal splenic artery embolization, so way to go. So I'm going to talk about percutaneous enteral access, and I'm passionate about this topic because as I've become more seasoned throughout my career, I have seen the morbidity and mortality that can occur from this apparently innocuous set of procedures that we offer. Our fellows and residents that we train can quickly gain the skill set of putting a tube in a distended air-filled viscus such as the stomach, but the trouble that you can get into is not always apparent. And so I want to share a little bit about how we do it and some of the complications that can occur. I have no disclosures. And of course, there are multiple different access routes for enteral access percutaneously. I'm going to talk mainly about gastric, a little bit about transoral, and then esophageal access. The techniques that I will describe will include dilator sheaths, balloon-assisted gastrostomies, gastropexy, and complication management and imaging. Gastrostomy has been around a long time. Surgically, it was developed in the 1800s. Percutaneous methods came along in the 1970s endoscopically, and then fluoroscopically in the 1980s. And when I started my training, it was really taking off as a procedure that interventional radiology participated in. Of course, there are standards of practice for gastrointestinal access. And if you have any questions about that practice, I would advise you to refer to the Society of Interventional Radiology guidelines, which are also done with gastroenterologists and surgeons. When do we get the call? Well, a lot of practices have a very robust percutaneous enteral access service, but often we get the complicated patients that others have trouble with, such as difficulty transilluminating with endoscopy, surgical changes, and the high-risk patients. We place all the gastrostomy tubes in our ALS patients here at Mayo Clinic, utilizing a regional block and little to no other anesthesia or sedation. So we can do these safely, effectively, and very quickly. And of course, Friday after 3 p.m., we seem to get everything. Contraindications, there are a few absolute ones. Uncontrolled coagulopathy, an obstructed GI tract if you're planning on feeding the patient, but maybe you would put a G-tube in if you're venting in a malignant obstruction. Active peritonitis, bowel ischemia are some serious reasons to probably avoid this procedure. In the relative category, it's less definitive, but there are complicating factors such as intrathoracic stomachs, colonic interposition. Of course, large volume ascites is not a good thing, and you either need to drain that or find a way to work around it. Peritoneal dialysis, similar situation, and portal hypertension with large varices. The choice of a catheter for a gastrostomy is driven by the customer, in my opinion. The nutrition team, the referring physician, and the patients are all part of this team that helps decide how these patients will be handled. We use a large silicone tube, which is similar to the gastroenterologist that place, but other departments will place standard pigtail drains that are tapered catheters and very easy to put in. So there's not a right answer, but you need to talk to your customers. I want to talk just for a few minutes about gastropexy. If you don't know what a gastropexy is, that's when we fasten the anterior gastric wall to the anterior abdominal wall. It's done with a small T-bar placed through a needle into the stomach. There is divided opinion on whether to perform gastropexy. We do use gastropexy in our practice. We believe it reduces the risk of peritonitis. It can tamponade, reduce the risk of bleeding. It makes early replacement of clogged tubes easier with the stomach held in place. I believe it also makes it easier to put large bore tubes like we use, and reduces the risk if you're dealing with ascites. The downsides of gastropexy is that they can cause cellulitis or erosions, and if you forget them, they can get to be a mess. We currently are using a gastropexy suture that should dissolve, but we don't trust that. We bring our patients back at 10 days and release our gastropexy. So here was a study looking at this that came out in favor of gastropexy as reducing complications and making the procedure more durable and effective. So the most frequent complication I mentioned is skin excoriation or cellulitis. So you need to have a good follow-up program to monitor your percutaneous enteral access and remove any anchors or release them in 10 days. Our technique, we give a first-generation cephalosporin as a prophylactic antibiotic. The patient may come with an NG tube or a nasojejunal tube prior. If not, we place one. We give glucagon to inhibit gastric peristalsis because we're distending the stomach with air. Of course, we use moderate sedation unless it's with the ALS patients where we use a regional nerve block. Some optional maneuvers are to give dilute barium 12 hours prior to the procedure so you can identify the transverse colon. And some operators use ultrasound to outline the left lobe of the liver prior to access. The most important thing is to get a good insufflation of the stomach via the nasogastric tube. The reason this is so important is to displace the colon, bring the stomach up to the anterior abdominal wall, and I believe this is directly responsible for a safe procedure, so you need to do this effectively and completely. If you cannot get an NG tube down, I have stuck the stomach directly with ultrasound, achieve a needle, and puff a little contrast, finding the lumen of the stomach, and then inflate it with air directly. So there are many different ways to achieve this goal. As far as the site selection in the stomach, it's a junction of the upper 2/3 and the lower 1/3 of the stomach, midway between the lesser and greater curvatures. In these images, you can see the gastropexy anchors. There are 3 here, and the puncture for the gastrostomy tube is made through the anchor bed into the body of the stomach. Of course, the reason to avoid the lesser and greater curvatures is to minimize the risk of arterial injury. As I mentioned before, we talked about gastric distension, the site selection, the gastropexy, and then we place a wire through the needle, loop it in the antrum, and then we use a sheath technique to dilate up to a large peel-away sheath and insert the G-tube through that. The retention balloon is then inflated and a contrast injection and tube check are made. Here are a couple of images just demonstrating this very straightforward technique of looping the wire in the gastric antrum using a dilator set to get your large bore sheath in place. We typically will use a 20 French peel-away sheath for an 18 French Cook gastrostomy tube. And here's what the final result should look like. No extravasation of contrast and the retention balloon within the gastric lumen. And I did want to mention the other technique that's used for gastrostomy and popularized by Peter Bream at Vanderbilt and now UNC. And these are some images from his YouTube video that you may want to look up. He inserts an 8mm balloon, 8 centimeters in length, through the gastrostomy tube. And then that is inserted through the puncture site and inflated. That opens the gastric wall. And as the balloon is deflated, you can slip the G-tube in. Also an equally effective and good way of getting a G-tube into the stomach. This image is to demonstrate the difference between the tubes we often use, which is the upper one, the silicone tube, and you can see the retention balloon on the end of the catheter versus a mushroom type gastrostomy tube. And they're proponents of both types of these tubes. I would say that if you're using a balloon retention tube, you need to have very reliable nursing care and staff so they do not accidentally deflate your retention balloon, because a balloon that comes down and a gastrostomy tube that moves could lead to disaster with feeding into the peritoneum. So you've got to have a very tight team and good nursing care to use the balloon retention devices, and that's primarily what we use. Others in interventional radiology and in GI will use the mushroom retention device, where it is pulled through the mouth with a snare down through the esophagus and out the stomach. And this can be done percutaneously by interventional radiologists. I will use this technique for patients that persistently pull out their tubes or rupture their balloons, and it's performed by directing a catheter up the esophagus, out the mouth, and with a snare pulling this tube down the mouth, through the stomach, and out through the abdominal site, leaving the retention mushroom inside the patient's stomach. Also very effective. Feeding, we used to wait for 12 to 24 hours. There is now a body of evidence that confirms it's safe to feed patients within 2 hours of uncomplicated access. It's important to flush the tubes, and we all know to work very diligently to avoid crush meds being placed through your tubes, because they'll just come back clogged if that continues. And we find that clogged tubes are best managed by exchange. The results, of course, are very good for technical success. The PRG is the radiographically placed G-tube by radiology, very high success rate compared to endoscopy or surgery. Mortality, of course, should be very, very low. And because of our effectiveness and our low complications, we have found very great success in developing and maintaining this practice. Now, I wanted to bring up this topic, and I'm not sure how many are aware of this, the percutaneous transesophageal gastrostomy tube. Kara, can you put up the poll? I would like to ask everyone, are you aware of this procedure, yes or no? But I'm just curious how prevalent the transesophageal gastrostomy tubes are around your practices, where the patient receives the access through the neck into the esophagus. So about 1/3 yes, 2/3 no. Thank you, Kara. So let's talk a little bit about it. This is what it looks like coming out of the patient's neck. It's a low cervical access. Here's what the radiographic appearance would look like after the tube is in the stomach. And why would we do this? Well, typically it's because of ascites, large varices, peritoneal carcinomatosis, tumor infiltration of the stomach, a host of reasons. And typically our patients are those that have peritoneal carcinomatosis or some reason that it would be very dangerous to directly puncture the stomach. They're often for palliation, and they are very effective in that regard. They can be performed by multiple disciplines. The success rate is very high. If there's mortality, it is almost always due to progression of underlying disease. Complications have been very, very low, and we've had almost no problems with these tubes at all. There is always a risk of injury to the neurovascular bundle in the neck, but I'll show you how we try to avoid that. This is an ultrasound image of the left low cervical neck during a planned access for a transesophageal gastrostomy tube. The target down here is the esophagus, which may or may not be seen with ultrasound on initial scanning. The left lobe of the thyroid gland is protecting the area that we want to go. And then we have the carotid and the jugular also in the way with a very difficult access window where we're trying to get the needle to the esophagus. So the way we overcome this is to put a 12 millimeter or larger balloon in the cervical esophagus and blow it up with dilute contrast. This technique has been described and is used by multiple practices. And then we're able to successfully get a window that separates the left lobe of the thyroid from the carotid, and we puncture the balloon under ultrasound and then fluoroscopic guidance with a 21 gauge needle and coil a wire within the balloon in the cervical esophagus. And then this balloon and the wire that it contains can be just advanced down the esophagus, giving you percutaneous access to the esophagus. And then with dilators and a stiff 035 wire, we end up with typically a 10.2 for inch, 60 centimeter multi-purpose drain in the stomach, and is very effective as a gastrostomy tube with minimal morbidity. And as I said, works very well for the right patient population. So now I would like to talk about some of the things that I would really like you to be aware of in your practices and when you are involved with these types of tubes. Number one, of course, is infection or ulceration that can occur anytime you place a tube. And we're really set up for these a lot of times with the patients that are malnourished, they're diabetic, and a lot of these patients are not in the best overall health. And so it's important to recognize on follow-up cross-sectional imaging or in follow-up rounds on the floor when cellulitis or necrotizing soft tissue fasciitis may be getting started. And these are exacerbated by overly tight gastric anchors or bolsters on the G-tube. So we teach our trainees, don't make the anchors extremely snug, just tight enough to hold the stomach in place. So we leave them a little bit on the loose side, and then the bolster on the G-tube, again, not overly snug, leave some room. An associated complication is peristomal leakage. This happens to everyone, again, associated with malnourished patients and diabetics. These are very difficult problems when they start to occur, and they are not solved by just putting larger tubes in because the hole just keeps growing. So in some of these patients that are more remote from the procedure, we can pull the tube out, and over 24 to 48 hours, the hole will begin to close. And you can come back in and put a tube back through the tract and succeed. In other cases, it may require abandoning the site, letting it heal, and coming back with a new access. Inadvertent G-tube removal happens again to everyone. If it's very early and your gastric anchors or gastropexy is still in place, that provides that element of safety that you're looking for, and you can simply recannulate the tract if you catch it early, and over a wire put a new tube in. If it's still very early before tract maturation and you've lost your anchors, you may consider replacing a new set of anchors before you put the tube in. The worst thing is to displace the stomach from the abdominal wall, lose control of the stomach, and begin leaking into the peritoneum. So, of course, chronic patients who have had tube removal, it's very easy. Just slap a new tube in, and you don't have to worry about it with the tract being scarred and matured down. Something that can happen that's embarrassing that you should avoid is gastric outlet obstruction. If you let your balloon get through the pylorus and blow it up and fix the catheter there, you can make the patient very uncomfortable and very sick. And this needs to be recognized at the time of placement, and make sure your balloon is not trapped in the pylorus. In rare situations, the balloons can be advanced days or weeks later through the pylorus due to improper nursing care. But again, look for that as a possible reason for the patient's suffering. Bleeding, I'll show an example of that in a few minutes. Unfortunately, that's very rare, but it can be life-threatening. Peritonitis, this is the worst outcome that you could hope to see, often from malpositioned tubes and patients being inadvertently fed into the peritoneum. So we want to avoid this at all costs. Colonic perforation, again, very rare. I've seen it a couple times in my career. Once was due to peritoneal carcinomatosis when the colon could not be visualized and it was matted onto the stomach. So be careful if patients have peritoneal carcinomatosis. The other time was just an inadvertent procedure by a trainee when they did not recognize the situation. Tumor seeding has been reported in the gastroenterology literature of dragging large devices and tubes through head and neck cancers and seeding the tract for a gastrostomy tube. Radiology tubes, we use much smaller NG tubes. And if I know I have a patient with a head and neck cancer, I may use a 5-French glide cath and a glide wire to get nasogastric access to minimize any disruption or disturbing of the tumor in the head and neck region. But it has to be recognized as a potential complication and discuss it with your patients as appropriate. So here's some examples of complications that we've seen and ones that you want to recognize early. Here was a 72-year-old male with a soft tissue sarcoma of the thigh that had been resected. The patient was debilitated and required a G-tube for nutrition, but then developed abdominal pain subsequent to the G-tube placement. CTs were obtained. This was 2 days after placement. You can see a little bit of gas in the tract, which might bring some concern, but the tube is within the stomach. At 4 days, the situation is beginning to change. As you can see, significant traction on the retention balloon in the stomach. And certainly, if you're reading these images, please call whoever placed the G-tube to let them know about this, because this is going to lead to gastric wall erosions, ischemia, cellulitis, and difficult things. Unfortunately, this situation progressed through 9 days, and the tube pulled through the wall of the stomach, and then we started to see peritoneal fluid collections develop. And this patient had to be treated with antibiotics, peritoneal drains, the G-tube site was abandoned, and it was a delayed recovery before another enteral access could be placed. So important findings on CT imaging and follow-up: look for G-tubes that are too tight. Another case, 75-year-old female with a posterior fossa mass who had had a craniectomy for a neoplasm, difficulty swallowing, and needed a G-tube. Here is the immediate G-tube post-placement image, which looks good. It's an 18 French silicone catheter with a gastric retention balloon. Contrast is contained within the gastric lumen. But on CT follow-up, again, we see signs of cellulitis, infection developing, even though the tube is within the stomach, and this patient was leaking around their tube. Again, these are challenging problems to deal with in malnourished patients, and often require giving up the G-tube tract while healing with antibiotics is employed. So again, please report these if you see them to the proceduralist and let their attention be directed to immediate management as soon as possible. And this is what it may look like externally on the patient's skin. A lot of erosions, erythema, and breakdown of the skin. This is not necessarily a complication I would consider, but something that we deal with. I don't know how many of you have seen this, but this is overgrowth of the mucosa at the G-tube site. It can be tender, painful for the patients, and cosmetically, a lot of them do not like it. And so we are asked to deal with this. And the way to deal with this is usually silver nitrate applied with a stick. And to burn this down requires a lot of local anesthetic and even sedation for some patients to remove this exuberant tissue. Here is another, I think, one of our more interesting complications on a 72-year-old female having swallowing dysfunction after a stroke. Again, the initial G-tube placement image was relatively unremarkable. No significant difficulties were noted to be encountered during placement, but the patient going back to their room after the procedure immediately began not doing well, abdominal pain, and then became hypotensive and tachycardic, requiring pressure support. The patient was moved to intensive care and we got the call. Of course, a CT was obtained and demonstrates significantly abnormal stomach. In this image, you can see that the gastrostomy tube retention balloon is contained within the gastric lumen, but there is a lot of material within the gastric lumen, hyperattenuating. Some of this was most likely due to contrast placed during G-tube placement, but there was also a high degree of suspicion that an injury had occurred and there was active arterial bleeding, although it was difficult to point out the exact site of injury. But you can see the red arrows are pointing to this layering blood and edema of the gastric wall, necessitating additional intervention in this hypotensive patient. So we took the patient for an arteriogram, and this is a celiac arteriogram. Typically, we'll inject about 5 cc's per second for a total volume of 20 or 25 cc's. And this demonstrates the problem clearly. I'm sure most of you have already identified it. But the arteriogram is also very valuable for the great anatomy that it shows. You can see the inferior phrenic arteries bilaterally coursing up along the diaphragm. You can, of course, see the gastroduodenal artery and the pancreaticoduodenal arteries. So let's put up another poll, Kara. I'd like for you to identify the bleeding vessel on this arteriogram. Okay, so all of these arteries can cause perfusion to the, or are responsible for perfusion to the stomach, and all can be involved with various pathologies. So I think it's important to realize that this stomach is very distended. We see several votes for gastroepiploic and left gastric. So if we review the anatomy here, the gastroepiploic artery, I presume you can see my arrow, courses down in the normal location and off the bottom edge of the screen. Of course, it's the end artery of the gastroduodenal artery. And the artery that's bleeding is just to the right of the catheter at the bottom edge of the spleen. And this turns out to be a very distended stomach with very stretched left gastric arteries. And we, of course, would want to access this artery and control this hemorrhage. Before I show you how we did that, I would like for you to notice on the far right of your screen, you can see a left gastroepiploic artery coming off of the splenic artery. We don't usually see this well, but there is a collateral network between the right and left gastroepiploics that supply the greater curvature of the stomach. In this case, the left gastric artery, instead of arising directly off the celiac, came off the proximal common hepatic. And so with a reverse curve catheter, we were able to access the left gastric artery with a microcatheter and get more selective. And there's just an arrow showing the bleed in the distal left gastric artery. And the microcatheter is advanced to the level of the bleed, and several coils were placed, resulting in cessation of hemorrhage. And the follow-up arteriogram was also obtained of the gastroduodenal artery to make sure that the gastroepiploic artery, which you can see very well here in the right image, is not reconstituting the bleed, and indeed it did not. And this patient subsequently did very well. No additional interventions were required. The stomach cleared itself of the blood products, and the G-tube was able to be used several days after this intervention. So a very unfortunate complication, one that we do not see very frequently, but when it occurs, needs to be recognized immediately, obtain a CT, and get to arteriography for control of hemorrhage as needed. So that's the end of my presentation. My passionate plea is that gastrostomy tubes and their related interventions can be very technically easy to perform, but please remember to follow up your patients with rounds, with physical examination, and to remove your gastropexies and make sure that you leave the patient free and clear of all complications as possible. Thank you. I don't know if we have time for questions. If not, you can email me. My email address is there. I'd be glad to answer them. But I believe also that Kara said she would send the Q&A questions via email if needed. Thank you very much.
Thank you, Dr. McKinney, for a really wonderful presentation. And again, thank you for taking the time. Thanks to all the attendees. Please join us for our final session on Thursday. We'll have a nuclear medicine session, and we'll wrap the series up. So we'll talk to you then, and be well. And thank you again to Dr. Marx and Dr. McKinney for your presentations today.